Hey everybody, we're going to wrap things up on psychotherapy and units 12 and 13 in general with this set of video notes on evaluating the psychotherapies that are out there. This one will be much more brief in terms of the one that you watched yesterday. I know that was like kind of a monster, so we'll try to keep things as simple for you as possible. When we talk about evaluating therapies, what we're looking at is who are people turning to for help when they're struggling psychologically speaking. Most will end up going to physicians in some manner, nearly 42%, but a lot of people do seek out mental health specialists. Nearly 39% of those surveyed do. And you this other little piece of the pie that can be other kinds of professionals, such as clergy members or pastors, people who are important in the religious aspect of things. So once then we've gone from that point and we look at the mental health component, we take it a step further and see within those psychotherapies who is most likely used, who has the tendency to follow the most kinds of processes, of eclectic approaches, who seems to have the highest level of success, basically. If we look at it from that level, then cognitive therapies are the most widely used. I would know that. And I would also recognize that psychoanalytic is the second most widely used, followed then by family or group therapies. So those are the three. You got cognitive, psychoanalysis, and then family or group therapy. And you can see the varying degrees of breakdown in terms of percentage. It's not necessarily terribly well seen to go with the behavioral route, simply just because it does have to be very involved and very intensive. So usually if you see an alteration to the thought processes that correspond to a disorder, that can tend to lead to more positive, less maladaptive behavior. Clients' perceptions when it comes to how successful treatment will be or how successful treatment is really do matter. If you ask clients about their experiences once they got into therapy, they have a tendency to overestimate its effectiveness, okay? And that's something very much to keep in mind when we take a look at critically assessing whether psychotherapy really works. Clients that enter therapy in crisis, it's important to recognize that those crises can often end up just fading naturally and regressing toward normalcy. So even though people who have sought out psychotherapy at those points in times improve, that doesn't mean that it was the therapy that helped them improve. It could be just that the crisis resolved itself over time. It's also important to note that clients have a desire to believe that the therapy was worth the effort. If you're paying that much money and you're focusing that much time on attempting to improve something about your life, then you would hope and have a desire to think that it does have some level of worth and effort. So there could be a little bit of a mind over matter piece to that. The other thing to keep in mind is that clients generally speak kindly of their therapists. When you have high regard for someone, that can tend to translate to overstating some of the things that they did for you or some of the things that they attempted to provide for you while in therapy. So those are some things to keep in mind when taking a critical look at psychotherapies. Now, if you flip it around and you look at a clinician's perception, for example, what they're going to see is a level of success as well. They do believe that therapy is successful, but they do also kind of acknowledge that a client is going to be better off after receiving treatment rather than not, even if there are failures involved to things. Clinicians are aware of failures, but they tend to be a little more aware of the failures of other therapists. They don't want to necessarily acknowledge that they failed an individual in terms of the psychotherapy. And so that is kind of important to recognize. If a client seeks out another clinician, the former therapist is more likely to argue that the client developed some other kind of issue or struggle because they don't want to look like they're not able to do their job. And it's also important to note that clinicians are likely to testify to the efficacy of their therapy, the ability, the level of success, regardless of the outcome of the treatment. Clinicians will believe that what it is that they do works regardless of whether a person seems to have improved or not. So those are also important to recognize. The outcomes of research. Hans Eysenck, we recognize him from the varying spectrums of personality, stability versus instability, extroversion versus introversion. He also took a look at the effectiveness of psychotherapy. He really wanted to study that. And so something that he did was completed meta-analysis. This is one of your vocab terms that you completed for us. Meta-analysis is attempting to look at research studies that have already been done out there and then do your research on those research pieces. So it's kind of compiling research over research. That's a more simplified way of looking at what meta-analysis means. So Eysenck performed meta-analysis. And he suggests that from what it was that he saw, 2/3 of clients improved whether they receive therapy or not. So that does tend to lend itself to that possible skepticism that there are natural ebbs and flows to times in our lives that can lend themselves towards anxiety or depression. And so those can tend to resolve themselves over time. Some problems with Eysenck's assessment, though, and I can tell that you guys are probably all just like, why do we keep flipping back and forth? There's no real one decided upon answer for this. You got to look at all of the varying facets to it. So the problems with Eysenck's study, first and foremost, he only looked at 24 studies to analyze. So that's really, really, really tiny in terms of the amount of studies to take a look at. The second piece to this was that there were very few forms of psychotherapy available at the point in time that Eysenck was completing his research. Today, there are hundreds of different kinds of studies that are out there, and there are many, many different kinds of psychotherapy. It's important to recognize Mary Lee Smith did some analysis of 475 studies. So she did some hardcore meta-analysis, and that showed that there is some level of effectiveness for seeking out psychotherapy. That on average, better than 80% of, on average, people who sought out psychotherapy ended up better off than 80% of those that went untreated. So that does lend some evidence to support the argument that seeking out psychotherapy to address issues is effective. In general, those that undergo therapy are more likely to improve, but so are those that don't undergo therapy. So there's this quote here from Mary Lee Smith. It says, in general, those not undergoing therapy improve, but those undergoing therapy are more likely to improve. So it's not to say that if you choose not to seek out psychotherapy for your struggles, that you won't get better, but there is some evidence out there to support seeking psychotherapy to give you a higher likelihood of improving. So when psychologists ends up wanting to try to answer this issue, they complete, as we said, meta-analysis. They want to look at the effectiveness of psychotherapy and whether it is beneficial for someone to seek it out or not. They will pull data from multiple different kinds of studies to get to a one and done, combined, agreed upon answer. So, a way of kind of looking at that aspect of things right here would be something along the lines of kind of comparing it to the big 5 personality traits, that those were kind of all agreed upon after a bunch of research and analysis from many members of trait theory perspective. And so they all kind of agreed upon those levels of spectrum that people can fall on in terms of certain kinds of personality traits. So if you look at it like that, you make that connection, it might be a little bit easier to understand meta-analysis. So outcome research. Research shows, as we said earlier from Mary Lee Smith's research, that treated patients are 80% better off than those that are untreated. And so you can see this image from your textbook, that we have kind of this averaging out. There is a normal bell curve that presents itself with this. So this is regular levels of standard deviation in terms of percentages that fall within the mean and within varying different standard deviation pieces. And so it showed that if you look at it from this perspective of the poor outcome, 80% of those that went untreated, they had poorer outcomes than those who sought psychotherapy. When we discuss this concept of effectiveness, it's important to recognize how effectiveness in general is a relative term. What may be effective to me isn't necessarily effective to you. What may help me if I were to have depression may not necessarily help you if you were to have depression. So which psychotherapy is going to be most effective for treating a particular problem? You want to look at this breakdown here. If you don't have any space to be able to write this down for yourself on the notes sheet itself, write it on a sheet of loose leaf. This is so, so, so important. It will show up on that AP exam, I guarantee it. For depression, the best kinds of therapy are going to be behavior therapy, cognitive therapy, and interpersonal therapy. They do a very good job of attempting to address the maladaptive behavior and the maladaptive thoughts that cause the depressive cycle to continue that we talked about in notes earlier. For anxiety, you've got cognition, very, very helpful in attempting to address those maladaptive thoughts. You've also got exposure therapy that works very well. Think back to the big burly scary guy that we saw on My Crazy Animal Fears, that old clip in class. And they also use the stress inoculation, attempting to teach a person how to properly respond when stressful situations are presented to them. For bulimia or other kinds of body dysmorphic disorder, you see combinations of cognitive and behavioral therapy. For phobias, you look at behavioral therapy, so we're looking at aspects of the conditioning, counter conditioning, exposure, systematic desensitization. You can also look at token economies for behavioral perspectives as well. And even something like bedwetting, as simple as that kind of behavior that little kids can struggle with and that can end up impacting them later on in life. They know behavior modification addresses that. One of the things that often is addressed when kids struggle with wetting the bed is cutting off the amount, limiting the amount that a child drinks at dinner, but also limiting the time frame in which that child can drink. So if they go to bed at 9 o'clock, they've got to cut it off by 5:30. So that way, they're able to address the behaviors themselves to alleviate the problem. So which type of therapy is best? Short answer and the cop-out is no one type of therapy has been found to be superior. Even though cognition tends to be the one that's most widely used, it's not necessarily the one that is most applicable or most helpful. There appears to be little, if any, connection between a clinician's experience, the kind of training they've had, the amount of supervision they've undergone, and even the licensing that they've had to move through in terms of requirements, and the outcomes that their clients give. So therapy is most effective when the problem is clear-cut and specific. So that way there is a problem-solving structure that can be implemented. Because if we know this second bullet point here, that there's little connection, there's little correlation between a clinician's level of experience and their training and the outcome of the patient, that means that those who've been in the field for an extended period of time aren't necessarily going to be any better than those who haven't. Psychotherapists will strive to tailor specific treatments to the individual. They're going to try to use, as we've said, an eclectic approach to help people, because while some symptoms of disorders are going to be very general and broad and applicable to many people, they won't necessarily be in terms of causes or presentation of the symptoms. And so that's very important to recognize when the therapist is attempting to tailor the treatment that they're providing to their patients. So, other things to take a look at, this is mentioned in Reading Guide 13C, but there are alternative psychotherapies out there other than the major ones that we looked at with biological psychoanalysis, cognitive, sociocultural, etc., etc. You could use something called therapeutic touch. This is when a therapist tries to move their hands a few inches from the client's body and they try to kind of push energy fields into balance. It kind of involves some more out there, out of the norm aspects. They reference things like Reiki which is kind of your energy level that you put out into the world. So the problem with therapeutic touch is it seems very kind of touchy-feely, but there's no real science behind it. It doesn't seem to have any level of success in working to cause people to alleviate and address their problems properly. You could also use something called eye movement desensitization. So you have people move their eyes back and forth while attempting to remember a traumatic experience. And you try to get them to reprocess how it is that works. But unfortunately, again, this is another kind of alternative that doesn't seem to have really high levels of success. You could use something like light exposure therapy. This has been helpful for people that develop seasonal affective disorder. Basically, it's kind of a mild depression during the winter months because, people don't get out as much. The weather is just really gloomy. Just take the winter of 2013 and 2014 as it is that people have gone through it. It's been snowy, just absolutely terrible, very, very, very frigid and cold, just not very conducive to getting out and interacting with people. You just kind of stay home by yourself. And so that can end up leading towards seasonal affective disorder. And they found that if you expose people to light, if they struggle with SAD, it has had some level of impact for the good to help those people's symptoms improve. And this has been scientifically validated. So we are a little more inclined to veer toward this than, say, the therapeutic touch or something along those lines. Now, therapists and their training. This is some stuff we talked about back in Unit 1, so I'm not going to spend a whole lot of time re-emphasizing it for you because it's something we've already learned. But most clinical psychologists have a PhD. They're experts in terms of research, assessment, therapy, and they have gone through a supervised internship. So they do have a very strong background in properly being able to help people address their problems. Clinical psychologists are going to help those that struggle with difficulties, but they will be more along the lines of everyday kinds of problems more than anything else. Clinical or psychiatric social workers, they have master's degrees in social work, but they also have post-grad supervision in the psychiatric component of things, being able to offer psychotherapy to those that they work with through their job, mostly the people, again, that have personal and family issues. So we're not dealing with the hardcore kinds of very, very, very disordered behaviors. You can have counselors. They can be pastors, they can be clergy members, they can be just regular everyday people in the community. They'll deal with abuse. They can be vocational counselors. Some people can develop depression when they struggle to be able to figure out what direction they want to go in their life with their job. They can help work with substance abuse or people who are coming back from physical or mental abuse that occurred to them when they were children or even as adults. And then you get to the psychiatrists. These guys are the ones that deal with the really heavy cases. They are medical doctors, so they hold medical degrees and they can prescribe medication. They've gone through med school, they've gone through medical residency, and they've gone through an internship in psychiatry in particular. So they are very well versed, very knowledgeable, and they've had extensive levels of training. So this is what differentiates them from many of the other areas of therapy, because unless you are a psychiatrist, you cannot prescribe medication for your patients, which is something very crucial in this day and age when everyone seems to think meds are the be-all, end-all. So, is there any possible way then to prevent psychological disorders from happening? We've discussed many that are out there that have nurture-oriented causes to them. Preventing psychological disorders means removing certain factors that come into play in societies relatively naturally in terms of many people's mentalities. Constant levels of criticism. Some people are just very critical of others, and that's because of things that they've learned from their own prior experiences. There are societies that are based off of racism and sexism, and so they find themselves holding on to those ideologies. And so in order to prevent many psychological disorders that can end up occurring because of those problems, you've got to eliminate those factors from society. And there are many who argue that that's just not a realistic expectation. But on the opposite end of things, you have the more positive, optimistic individuals that believe mere exposure effect, that the more that you expose people to others who are different from them, the more they start to recognize their commonalities and their similarities, then they're not perceived as different any longer. And so those attempts at prejudicial and stereotypical behavior tend to go away. So it just kind of depends. So mental health programs that are out there, advocates of preventative mental health care argue that a lot of disorders out there are due to social conditions. We've discussed that. DID, development of depression, development of anxiety, in some circumstances, even the development of some somatoform disorders. So to prevent those disorders, you got to change the environments themselves into more nurturing, positive, optimistic kinds of scenarios where it fosters growth and self-confidence. And considering that we've seen that cognition is the most widely used kind of therapy out there that attempts to, improve the way that people think about themselves and their disorder, we can kind of see how that makes sense a little bit. But at the end of the day, what we are looking at when it comes to psychological disorders, regardless of the therapies that are involved, or how the disorders are caused, or the environment in which an individual is raised, it is a constant combination of biopsychosocial factors. So while there may be biological considerations, genetic predispositions, physiological factors that cause things, there are also psychological, the thought processes and the patterns of thinking that can influence. And there are the sociocultural factors as well, the environment in which the person finds themselves. So for many within the field, environment in and of itself is not the sole cause, nor is it the sole thing that would need to be addressed when it comes to preventing mental disorders from formulating in the future. So this is the tail end of our video notes. Told you it would be a whole lot shorter than last time's. If you have any questions, let me know, but we have one more unit to go and you are officially finished with all of your AP Psychology content.